Welcome, everyone. We'll just wait a few more seconds for everyone to come in. Okay, I'd like to welcome everyone to our Ask the Experts webinar today. My name is Felicity Emerson. I'm the Scientific Director at ALD Connect, and I'm also a genetic counselor. And I'm really pleased to be joined by several prominent experts in the ALD field who are here today to answer your questions. So I'm going to have them introduce themselves, but right before they do, I have to read our disclaimer that we always show for ALD Connect webinars. So this webinar is for informational purposes only. The discussion is not intended to be a substitute for professional medical advice, diagnosis, or treatment. If you or a family member are ill or suspect that you or a family member are ill, seek professional medical attention immediately. ALD Connect and our partner speakers do not recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned during this webinar. And always remember to consult your healthcare provider with any questions regarding adrenoleukodystrophy. So with that, I'll turn it over to our speakers to each introduce themselves briefly with their name, their specialty, where they work out of, and then we'll start off with questions. Dr. Kemp, do you want to go first?
Yes. Okay, my name is Stefan Kemp. I am a full professor of inherited neurometabolic diseases and newborn screening at the Amsterdam University Medical Center. I've worked my entire professional career on ALD, and during my PhD studies at the Kennedy Krieger Institute in the late 90s, I started the ABCD1 variant registry together with Professor Hugo Moser. And this registry, what many ALD families and patients don't realize is that this registry is unique in its kind. There is hardly any other disease that has a registry like the one that we have for ALD. In 2019, my colleague Dr. Mark Engelen and we nominated ALD for newborn screening, and following a successful pilot program in the Netherlands, ALD was added to the Dutch newborn screening program in October 2023. And in 2017, I started the Gray Zone project to support families with uncertain diagnosis following newborn screening.
Thank you, Dr. Kemp. Dr. Regelman, do you want to go next?
Sure. I'm Molly Regelman. I'm a pediatric endocrinologist at the Children's Hospital at Montefiore Einstein in the Bronx. And I started taking care of ALD patients a little bit before newborn screening started in New York in 2013, but have been working on writing guidelines for monitoring for adrenal insufficiency in ALD.
Thank you. Dr. Smith-Fine?
Hi, nice to see everyone. Amina Smith-Fine. I'm a neurologist and a developmental pediatrician at the Kennedy Krieger Institute in Baltimore at the Moser Center. And so, I, together with several other neurologists there, really focus a lot on clinical care and natural history research and trials research in ALD, as well as other leukodystrophies. It's probably been about 7 years now that's been one of my primary focuses, and I particularly do a lot with home assessments of what's happening with walking and balance, trying to follow disease progression of myeloneuropathy symptoms in both men and women with ALD.
Thank you. Dr. Lund?
Hello, I'm Troy Lund at the University of Minnesota. I'm in pediatric bone marrow transplant and have had a long-standing interest in ALD, transplantation for the disease, biomarkers, and outcomes. I have a large ALD clinic seeing men, women, and children, as well as a very large biorepository. Happy to be here. Thank you.
Thank you. Dr. Mussolino?
I'm Patty Mussolino. I'm an associate professor of neurology at Harvard Medical School. I'm a neurologist that sees adults and kids with different neurogenetic conditions. I have been working on ALD since I met Dr. Eichler in 2005. So it's now more than 20 years. And I've been an investigator in the clinical trials for gene therapy as well as small molecules to treat primarily cerebral adrenoleukodystrophy. And I also lead a group of Latin American clinicians and researchers trying to help families with this condition in Latin America specifically. I'm so glad to be here and also with my colleagues to answer the questions that the community has.
Thank you. Thank you all for being here. And thank you to everyone who's registered and submitted questions. We do have many of your questions that have been submitted in advance planned out to get answered tonight. And time permitting, we'll also take live questions if you have additional questions that come up today. So you can submit your questions via the Q&A function. And if we have time, we'll get to those as well. So we're going to take questions by topic, and our first topic will be the gray zone and genetics, partially because Dr. Kemp has very kindly stayed up until midnight, Amsterdam time, to be with us tonight, and so we want to let him get to bed before it's too late. So before we start with the questions, we just wanted to briefly touch on what is the Gray Zone Project. And there has been a recent publication called the Gray Zone Project, Risk-Based Classification of ABCD1 Variants in X-linked Adrenoleukodystrophy, which has sparked many thoughtful and important questions from community members. And the Gray Zone Project is a very important research project led by Dr. Kemp. And with many collaborators, including Dr. Lund. So we're very lucky to have both of them with us today. And the main goal, as Dr. Kemp stated, of the Gray Zone Project is to study variants of uncertain significance, or VUSs. And VUSs are genetic variants, which are also known as mutations or spelling changes in the gene, which are not well understood and which current scientific evidence cannot determine whether that variant is pathogenic and if individuals are at risk to develop ALD or if it's benign. Only individuals with a VUS in the ABCD1 gene and no family history of symptoms in individuals with that variant fall into the gray zone. So we are very encouraged by the potential of this research to improve how we understand risk and disease monitoring and progression in the future. This publication represents meaningful progress and reflects the strong commitment of researchers to address critical unanswered questions in ALD. However, while we're very excited by this process and the progress that has come out of this publication, it remains research and is not clinical guidance. So patients and families should be careful not to deviate from or modify their monitoring schedule, testing, or clinical care unless specifically directed by their treating physician. And as always, make sure to contact your treating physician with any questions about ALD. Okay, so Dr. Kemp, first question for you. Someone asked, my son has a variant of uncertain significance, no family history of ALD, but my C26 lyso-PC from your lab is in the ALD range. Do we need to continue the monitoring protocol?
That's an excellent question. So I will first start with the short answer, and that is yes, absolutely, by definition. And then a little bit more, a longer answer, like a minute or so. So your son's variant is classified as a VUS, and it's simply because it has never been seen before. So there's no prior information to tell us whether this variant causes disease or not. And that uncertainty is real. So what the Gray Zone project does is that we add a crucial piece of information, and that is the C26 lyso-PC test. And that's a diagnostic test that is performed in a diagnostic laboratory in Amsterdam. And this test has been in use since 2018, when the lab that has been done plasma variant chain fatty acids for over 40 years shifted to C26 Lyso PC because simply it's much better, it's superior, it's faster, it's also cheaper because it's quicker. And it's really, really reproducible and it's not affected by diet or something. So what we do in the Gray Zone project, the lab analyzes the C26 Lyso PC in dried blood spots or in plasma in a diagnostic assay, and the results are compared to that of over 1,800 controls and more than 215 confirmed ALD patients. So we really have a good idea of the normal range and the ALD range. So in your son's case, the result is falls in the ALD range, and that is biochemical evidence that the variant is infecting the ALD protein to such an extent that the biochemistry is in the ALD range. And yes, absolutely, monitoring is warranted and it's essential. So stick to the protocol and the guidelines, absolutely.
Great, thank you. Next question is, does C26 lyso-PC measurement in your high-risk ALD range guarantee that someone will definitely develop cerebral ALD?
Yeah, that's another excellent question and a very logical one. So again, first, the short answer, no, there's no guarantee. So what we can only confirm that the variant we can only confirm that a variant is benign, meaning no ALD, and therefore a false positive screening result. And this is when the diagnostic test shows a C26 lyso PC level that is in the normal range. So, or that the variant results in C26 lyso PC levels that fall in the ALD range. So we can only do that. So it falls in the normal range or it falls in the ALD range. What our research has shown, and we've published a few papers in the last few years, is that there is a strong correlation between C26 lyso PC or other variant chain fatty acid containing lipids and disease severity. But that's at the group level. So at an individual level, we cannot predict the future of an individual. Because besides the variant in the ALD gene, there are more factors that determine whether a boy or a male develops cerebral ALD or not. So at this moment, we cannot predict this outcome. And I hope that answers your question.
Yes, great. Okay, third question. How do I participate in the Gray Zone project?
Oh, that's a very brief answer. So we can save a lot of time here. Contact Kelly.
Kelly Miettinen, our
At ALD
Executive
Connect.
Director of ALD Connect.
Yes, yes. Yeah,
Yes.
and so maybe I can add so families that receive genetic reports, they often come from yeah from other from I don't know commercial companies, labs, and we've noticed that, and that's also a part that we demonstrated in the Gray Zone paper, is that quite often or sometimes, let's say, these diagnostic report, these genetic reports do not align with the ABCD1 variant registry, and the ABCD1 variant registry is actively maintained with the help of many of the physicians that are here on the call, because if they see a patient that is clinically affected and a certain variant is found in this patient, we know that that variant is causing ALD. They contact me and I update the registry. So, and that is very different than many of the resources that other labs or companies use. So I would say the first thing is look at the registry. If your variant is there and it also said at the registry it says it's a FUS, then we honestly have no idea about this variant. So by definition, this variant qualifies for the Gray Zone project. If you are in doubt, contact Kelly or contact me because my email address is at the registry also, and I'm sure you can. I'm not that easy, that difficult to find. So just contact us and ask us.
And you can always get in touch with Kelly or ALD Connect staff
Yes.
by just emailing any of the ALD Connect infos,
Yeah.
ALD Connect emails at info@aldconnect.org.
Yeah.
Okay, great. Okay, now the last question for you, Dr. Kemp, is Does highly skewed X inactivation correlate with more severe symptoms in women? And maybe just for listeners who don't have as much of a biology background, could you start by explaining X inactivation and skewed X inactivation?
Yeah, well, again, first the short answer, yes. The published evidence supports this notion that X inactivation, skewed inactivation correlates with severity. Okay, so women have two X chromosomes, but each cell has only one of these X chromosomes active, and this X chromosome that also harbors the ABCD1 gene. It can have a healthy copy of the ABCD1 gene or the affected copy of the ALD gene. So let's call it a healthy X chromosome and an ALD X chromosome. So each cell has one of the two active. This means that a woman's body is mosaic because women have two X chromosomes. Males only have one X chromosome. So in males, by definition, all the cells have the same X chromosome active. So in a woman, some cells, from an ALD biological standpoint of view, some cells function normally and others do not. And the balance between these two populations matters. If more than 50% of the cells in a woman's body express the affected ALD gene, and that's a pattern that we call skewed ictin activation because you expected the ratio to be 50-50. But if it's 70-30 or 80-20%, then we call this skewed ictin activation. And then it matters which of the two X chromosomes is more active in the body. If more cells have the healthy ALD gene active, then it correlates with less symptoms. If the majority of the cells have the affected ALD protein active, then it correlates with more symptoms, more severe symptoms. So in short, X inactivation skewing helps to explain us why some women with ALD remain largely asymptomatic, so when the majority of the cells are healthy, while others develop significant neurological symptoms when the majority of the cells are ALD.
Great.
I hope this is clear.
Yes, very clear answer. Thank you very much, Dr. Kemp, and thank you for staying up late to talk to us. Our next set of questions will be about endocrinology, so will be directed to Dr. Regelman. Dr. Regelman, the first question is, what clear red flag symptoms during illness should prompt emergency care in someone with adrenal insufficiency, despite stress dosing and sick day protocols?
So I want to just start out by saying that you should be in contact with your pediatrician or your pediatric endocrinologist if your child is sick in any way, or if you're an adult with your adult doctors to discuss and stress dosing. The signs that would prompt me if a parent were calling in to suggest going to the emergency room are the same things that typically will make you go to the emergency room. So if there's alterations in how you're responding, if you're not able to keep the medicine down, so if you can't take your hydrocortisone stress dose because you have so much vomiting or the child has so much vomiting, or you seem very dehydrated, there's anything that would trigger going to the emergency room, typically I would say you should go, but then the not being able to keep the medicine, the hydrocortisone down would be the big red flag, I think, for prompting you to go to the emergency room. And along those same lines, if you've administered an the intramuscular injection of hydrocortisone, that should also prompt an emergency room visit and should be thought of as the bridge to getting to the emergency room.
Thank you. The second question is, what guidance exists for managing puberty and hormonal changes in boys with ALD and adrenal insufficiency?
So this is a little bit of a longer question. I'm going to say there's no specific guideline, but if you have ALD, you should have an endocrinologist involved in your child's care. And every pediatric endocrinologist monitors growth and puberty. That's the bread and butter of pediatric endocrinology. And each child's growth and pubertal development it will vary quite a bit. With ALD specifically, if you are taking hydrocortisone because you have adrenal insufficiency, you want to make sure that you're getting enough, that you are growing well, that you're gaining weight and you're hungry, and eating appropriately, but you don't want to have so much hydrocortisone that it's preventing you from growing well. And your endocrinologist should be able to find the right balance of hydrocortisone for that. Um, Puberty timing can vary a lot for any boy and can start as early as 9 and as late as 14. And even sometimes there are family variants that are totally unrelated to ALD, where puberty can start even later and be normal for the family. So I usually use a guide of what's been happening in the family with other family members for puberty to understand what timing is going to be likely normal for that boy, but also know that some of the treatments that some boys have to have, including transplants and the chemotherapy, can influence puberty timing as well. So, um, all of those things have to be considered. And then usually your pediatric endocrinologist will monitor hormone levels if it's appropriate. But I would also say that it's not necessary for a lot of boys to do that. It's only in the situations where it seems like something, either a medication or just something doesn't look like it's following the typical time course, that it would be necessary.
Okay, thank you. The third question is, after stress dosing steroids for 1 week, is a steroid taper required in children with adrenal insufficiency, or can they return directly to maintenance dosing?
So after 1 week, you can return to maintenance dosing. That's the quick answer. Um, the recommendations for tapering usually are, the latest Endocrine Society guidelines say that you can up to 3 weeks before you have to taper down. So as long as it's been under 3 weeks, you usually can just go back to physiologic dosing without needing a taper.
Thank you. And then the last question, how can I be prepared to travel with my child who has adrenal insufficiency?
So travel is, I usually tell everyone to just make sure you have everything with you when you go. So you should have your hydrocortisone tablets. You should have your injectable hydrocortisone and the syringe and alcohol swabs for administration. And then you should have a travel letter that gets you through the airports. And if you're traveling by car, you don't need that letter, but you should always have an emergency letter that you can hand to any emergency room doctor that explains what adrenal insufficiency is and what the first steps are for management. And also for me, we have our emergency pager number that then the doctors in the emergency room can reach out to us for any further guidance. And the Pediatric Endocrine Society has a statement on emergency management and preparation that pretty much every pediatric endocrinologist will follow something and have something similar, where they have an emergency letter that they can provide to families.
Wonderful. Thank you, Dr. Eckelman. Our next set of questions focus on adults and symptomatic women with ALD, and so they'll be addressed to Dr. Smith-Fine. Dr. Smith-Fine, the first question is, males and females are biologically different. Does this translate into different disease presentation or progression patterns?
Yeah, thank you for the question. I think, thankfully already Dr. Kemp laid out, nicely the biology about exon activation and differences between men and women biologically there. So that certainly is part of the rationale for why ALD presents differently. But just in terms of what we absolutely know from the natural history, in terms of men and women being different, this is maybe basics for, maybe some of you are well aware, but I'm just going to go for the basics just in case. But, we have our or several major phenotypes or ways that ALD presents, of course. And so cerebral disease, although of course the boys and men are at significant risk over a lifetime, and it's recommended to do MRI surveillance every year because of that risk. Cerebral disease is really extremely rare in women. So this is overlapping a bit with another topic, but the point is that it's not something that we're screening for or following regularly. That's a big difference, really, between men and women. Secondly, certainly there are cases of women rarely presenting with adrenal insufficiency, but again, that's also something very rare. At the Moser Center, we tend to do screening labs just the first time a woman presents to clinic, and we're doing a full history and neuro exam to do screening labs, but it's still not the same level of recommendation to continue doing that for women because of their very low risk. So that's another difference. In terms of the AMN or the myeloneuropathy symptoms, that's something that's been really over the last couple decades and recent years. We're understanding that, the more we ask women, the closer we look, the more it seems like really the majority of women eventually develop symptoms. Really, certainly by the time we're looking at women in their 70s or 80s, over 90% per the most recent estimates, or about 90% have these develop myeloneuropathy symptoms to some extent. And then sort of looking at what's more common, so certainly men would be more likely to develop some of the spinal cord symptoms in their, younger, in their 20s to 40s. For women, it's really not until about age 40 to 50 where the majority of women do report some symptoms. But they still can present earlier as well in their 20s and 30s. And we're trying to understand the factors that contribute to women having different risk or higher risk of having earlier symptoms and faster disease progression. There's still a lot of questions there. Hopefully that answers it.
Perfect. Thank you. The second question is something that we've been asked several times, and people want to know, are there lifestyle factors that appear to influence progression in adult men and women? Are there diet and nutrition interventions that have been studied that can help with symptoms?
Yeah, so it feels like our collaborators and, and investigators are starting to try to understand this more systematically, or to have more of an evidence-based approach to these types of questions. So one example, a good recent example is actually our German colleagues in Leipzig, Lisa Schaefer and Wolfgang Kohler had published a study. This is actually focused on women. It was I think 70 German women with ALD. They called it the SMART ALD study, and they actually specifically, over some months did, basically a virtual or remote lifestyle program. So there were different aspects that participants could opt into based on their needs, which is really smart. So if there were more psychological counseling needs, medical needs, neurologic needs, if they wanted to know sort of more about general diet and nutrition advice, and then also personalized fitness training. So it was a really comprehensive program that they could kind of pick and choose what was most relevant for them. And they didn't look, they didn't look at least at that phase or that with the published, with that published phase of the study at if it affected disease progression, but they did focus on quality of life, and quality of life related to mental health and other areas, and saw really dramatic improvements there. Again, it's just something that's important. Thinking about like day to day and how you cope, right, with symptoms and disease progression is also really important while we, wait for more curative treatments that are beyond just supportive or symptomatic care for women and for men. And then so that study, again, the data is published. The study is still posted on clinicaltrials.gov. And then, at the Moser Center at Kennedy Krieger Institute, we also have a clinicaltrials.gov study. It's on and off in terms of enrollment due to funding, but our ALD expert in research, or physical therapist Jennifer Keller, has this exercise intervention study that focuses on either progressive balance or progressive strength training, or even an adapted Tai Chi program to see if basically doing those targeted interventions over a couple of months does specifically affect quality of life, as well as some balance and walking measures. So that's ongoing. At this point, we still don't have great high quality evidence to recommend specific supplements or dietary changes, but I know this is also ongoing, and I think colleagues in Italy are maybe a little bit further in trying to delve into some of those questions.
Great, thank you.
Mm-hmm.
The next question relates to what you explained originally of that almost 90% or more of women with ALD will eventually get symptoms. So, given that, how early should women begin neurological monitoring, even if
Mhm.
symptoms appear to be mild or absent? And a related question, are there plans that exist to create formal standards of care for girls and women with ALD? And if you have any idea of what those guidelines might be, if they
Mhm.
would include brain MRI monitoring, if that's required for women with ALD, you have questions surrounding that.
Yeah, appreciate the question. The good news is that there already are guidelines that exist. Most recently published in 2022. This is international consensus guidelines for ALD, including the women. And so there's not a separate guideline for women, and I prefer I prefer it that way. That it this is all sort of the umbrella of ALD. I think it's important, and so it might take a little further looking because it's a long paper. It addresses lots of topics, and so you can see the recommendations for women interspersed throughout. Is relevant, but there's really a lot of great advice there, and there is a table. And I should say that we try to do so. It's a very scientific process. It's not just a bunch of folks getting together and saying we think this is a great idea. It's like a Delphi method, and so it tries in a unbiased way really to have essentially experts statewide and internationally to essentially vote or sort of rank their recommendations in these specific areas. So it's a very like systematic structured process, and so that again those guidelines were from 2022. My sense is that every few years we're probably going to be updating those. However, this is still recent, and there's a table within it that actually recommends for women screening starting at 18 years of age and older for the myeloneuropathy symptoms. So that includes history and a neurologic exam. Now, as I mentioned, cerebral disease development is exceedingly rare in women, and so there is not a guideline at this point to do annual MRI screening. I will say, just from a neurologist clinician perspective, considering that women, that I see in my clinic, they're sometimes of older age, into 50s, 60s, 70s. There can be other cognitive or neurologic challenges as well, right, that are not related to ALD. So I tend to have a low threshold. If there's something not quite right on the neurologic exam, or sort of a dramatic change that's worrisome, or a cognitive change that's worrisome, low threshold to get an MRI. But that's a decision that you would make, on an individual case by case basis with your neurologist. I just don't think that will make it into the annual screening guidelines. So yeah, and I think there's a lot of value in following up on a regular basis, even if you don't feel that you have symptoms yet. for several reasons. Sort of just think of it like primary care, that you're sort of looking out. Sometimes you don't know what you don't know about what symptoms could represent a manifestation of ALD. You could work with physical therapy or rehabilitation for non-medical approaches if things are not at a threshold for that. You can get educated about different medical approaches for when that is needed. Certainly understand what research is happening that women could be involved in, what the trial opportunities are. And then, of course, for younger women who are mildly symptomatic, you often, might be at a place of wanting to start a family or thinking about how, this affects you and your partner. And so it's a chance to get genetic counseling and just sort of be looped in and to stay educated. Also, unfortunately, we know from some, recent excellent papers looking at quality of life in women that even asymptomatic women tend to sometimes carry a high burden of, a higher burden than you would expect of mental health concerns. And I don't know if that's partly worried anxiety related to thinking about your own disease, sometimes about caring for your children or, your fathers. ALD affects families. And so there's social work and other support also that can be found with routine neurologic care. All right, long answer, but hopefully
A
helpful.
good one. Thank you. And then the last question to you for now, Dr. Smithvine. Someone submitted that gabapentin has not helped them with their leg pain. What alternative medications or non-drug approaches or rehab or PT strategies are showing promise for neuropathic pain?
Yeah, also a good question. And so I do want to step back in case this, helps the person who asked the question and anybody else. There are several potential different sources of pain in ALD, right? So neuropathic pain is one that we're well aware of. Unfortunately, having spasticity or, the tightness or increased tone, especially in the legs, can be a source of pain. Sometimes men and women will experience restless leg pain related to restless leg syndrome or discomfort related to that. And again, as we age, not everything necessarily will be ALD. There could be other comorbid conditions, like I see certainly women in my clinic with arthritis or other sources of pain. So the bottom line is a detailed history review of systems and a good physical exam is key to first sort of understand what's the source of that pain, and then you can match that. Your neurologist will be matching that to the appropriate medication strategy for it. Probably with a little bit of trial and error, unfortunately, but that information is first critical to say where should we start. So there's gabapentin, there's pregabalin or Lyrica. There's certainly a number of medication options used in ALD that can potentially address neuropathic pain. And then for spasticity, there's a bit of overlap, but there are certainly, distinct medications such as baclofen that specifically can be helpful for that type of pain. And then there's actually an ongoing study, if restless leg syndrome is a concern, especially for nighttime leg pain, there is an ongoing study looking at pramipexole, which is approved for RLS and other conditions, a study at Mass General that's trying to see if there's benefit specifically for women with ALD. So hopefully we'll have some information in the next year or so on that. And then otherwise, again, other approaches that help pain and actually can help pain of multiple sources would be, recommendations from physical therapy about, different exercises you can do for, stretching. If tightness is a concern, that can relieve some of the spasticity related pain, strengthening, and sometimes there can be imbalances between the right and left side of the body that make things more uncomfortable with walking. And so again, your physical therapist or your rehab medicine doc is going to be able to sort of hone in on what the strategies would be for that can indirectly improve pain. And then finally, I know that there are, again, the rehab medicine doc or the physiatrist, they're going to be the most well-versed, and even newer things like electrical stimulation applied to things like weak muscles that can affect walking and help pain. I know there's been just like at least one study I can think of that looked at E-stim and ALD, and the results were mixed, but it did help some people. So, this data again is coming out more and more recently.
Great, thank you.
You're welcome.
Okay, so now we'll move on to talking about therapies, current and future. And we'll start with Dr. Lund and then move to Dr. Mussolino. So, Dr. Lund, the first question for you is treatment ever appropriate for asymptomatic boys, such as gene therapy or bone marrow transplant, before MRI changes appear?
Mhm. Yeah, thanks for the question. It's a common question I get from parents. The short answer is no, it's never appropriate. And that's given that while transplant and gene therapy can be as safe as they can be, they do involve chemotherapy. And so, given that there is still some risk from the chemotherapy drugs that are given to kids, we spare them that risk and wait until their MRIs show active cerebral disease before we offer these therapies.
That makes sense. Thank you. The next question is, are transplanted boys followed indefinitely to track AMN outcomes later in life? And what does that follow-up include, or what should it include?
Yeah, I think it depends on where you've been transplanted and your follow-up schedule. Our clinic and myself follow these boys indefinitely on a yearly basis if the family can go back to clinic. And for following AMN, it's mostly physical exam and a team approach. So my team includes myself, a neurologist, a geneticist, genetic counselor, and a pharmacist as well. But it's mostly physical exam based, as well as taking a careful history about the patient, whether or not they're having neuropathy, balance problems, gait problems, neuropathic type pain, just like you would for somebody at risk of AMN who didn't have a transplant. Because we think that's a different process. Transplant probably doesn't impact it to the point where it would prevent it. And I tell no family that, yes, transplant prevents AMN, because it doesn't. And we do have some cases of AMN years after transplant.
Okay. And then the last question, specifically for Dr. Lund, is, are there combination therapies that are being explored? For example, gene therapy plus anti-inflammatory or neuroprotective drugs?
Yeah, that's a good question. I don't believe gene therapy is being combined with anything, but in allotransplant, we are combining it actually with immunosuppressive drugs before and during transplant, trying to reduce the inflammatory burden and improve outcomes for all patients with cerebral disease.
Great. Thank you, Dr. Lund.
Mhm.
Dr. Mussolino.
So I'm taking off.
Oh, thank you,
It was
Dr.
a pleasure
Kemp.
to join you, and next time in my time zone. Yep.
Yes. Thank you very
Bye
much for
bye.
staying up late.
Thank you, Stefan.
Okay, great. And then moving into more future therapies, Dr. Mussolino, will liraglutide be approved for boys with cerebral ALD in the US?
We do not know yet if the drug will be approved in Europe, where it's currently seeking approval. There was a multi-center clinical trial in boys with cerebral ALD. Took place in 5 different countries in Europe. In the US, the FDA, we will expect, is waiting for the results of the adult liraglutide trial. It's called CALIX. That is still enrolling patients to see if this small molecule that is agonizing something called PPR gamma pathway and has an anti-inflammatory and potentially mildly protective effect does also have an effect on slowing down the lesions in adult patients. So we expect that first the European Union, the EMA, is the FDA of the European Union, will be the first one in having a say with the results of the pediatric cerebral ALD trial that took place in Europe. And then following that, it probably will follow with the results of CALIX, the adult trial in the US, seeking the approval from the FDA. But the answer short is we do not know until we go through the process. What we know is what the drug's been able to show in imaging and clinically, at least up to 2 or 3 years of follow-up in the boys that were enrolled. And those results, the interim results, are published. and available, and the full final results are being submitted right now. So there will be also soon, hopefully, with the peer review process available to the community for everybody to see what we expect.
That's great. We'll all look forward to seeing those final results. The next question for you is what therapies are currently in development that might help infants who are now identified through newborn screening when they reach school age?
There is several efforts, and this is really a lot of hope, I think, for ALD as a community in trying to modify the risk that some of the patients, the boys primarily, will have on cerebral ALD. There are several groups, including academic groups and companies, that are developing different molecules and types of therapies to try to treat before the cerebral ALD occurs and treat also patients with AMN and women with ALD. I think some of the progress of that research is still in different stages. It's going to be shared with the community. We usually, in the annual meeting of ALD Connect, we have many of these groups presenting the results. But yes, there is a lot of groups, at least 6 or 7 new therapies in development that we hope will be applied for different types of stages of this ALD. In the next, I would say, anywhere from 2 to 5 years, we'll see some of those hitting the clinic.
Great. And then the last question for you, Dr. Mussolino, specifically, is as we're thinking about these new potential treatments and diagnosing more children, how can we promote equitable access to newborn screening, diagnosis, and these new treatments worldwide?
That's an excellent question and very close to my heart because we all, even in the US, I would say equitable is not equitable even in the United States to access even the standard of care. It's a complex disease. It requires a multidisciplinary team. But starting with the newborn screening, it requires a very coordinated effort by a government to really do this well. And a lot of the families here and in the community have been critical in making this implemented here in the US and in some countries in Europe at the moment. So that the journey is not simple. And the most important part is there has to be a direction of care after a baby is included in a screening for any disease. So once you have a baby at risk, there is everything that follows from confirming that is really a disease. And you have the early conversation about what happens here when things we don't know if they're really disease causing or not, like variants of unknown significance. You have to have infrastructure, physicians, genetic counselors, coordinators of care that allow for the direction of what happens after a baby tests positive on that dry blood in the heel. And the second part is that you have to be able to access care. So in a lot of countries that are not healthcare systems, for example, that are generalized or that don't have resources, even accessing the multidisciplinary care, pediatric endocrinologist, just to start, which is one of the very first actions that we have to have in the babies and is being evaluated by the endocrinologist, may not be accessible to where the patient lives. So there is a lot of challenges, which is once we provide this window for action, which is preventing an adrenal crisis, first and foremost, that's why newborn screening got approved, to screening the brain with regular MRIs in the boys only, not in the girls, starting at a certain age, following the international guidelines. And again, the access to getting to the centers that can image the patients. And the most important part, what do you do with the data that happens from this testing? And that does require expertise in the disease. It's not just a regular pediatrician in general that will follow these patients. They require coordination with neurologists, developmental pediatricians, neuroimaging experts that can really interpret the images. The lesions can be difficult to detect at the beginning. And very importantly, the coordination with the whole transplant teams, which we know may be necessary for some patients. in childhood, in teenagerhood, or in adulthood. So there is a number of challenges, and I think it's important that as a community, we try to find the best ways to guide that care and at the same time adapt it to be able to make it more accessible to people. So for many countries, MRIs every 6 months are not feasible. So what other biomarkers can we use that are not imaging, that don't require sedation? And there is a lot of efforts in the research side to try to determine if we can do a blood draw and say, okay, now we see inflammation in the brain. We might have to do an MRI now instead of having to put the kids through this. But that research, that work will take several years, probably more than a decade, to catch up with the best knowledge we have in the disease, which is the standard of care that we currently provide. So your monitoring and your follow-ups are critical to be followed. There is also a big push and opportunity across the areas with less resources to work together. You don't need 10,000 ALD experts. You just need a few that can help instruct and coordinate local care. So there is a lot of efforts in creating consortia, so communities of different expertise, the imaging that can review the MRIs for multiple regions, including different countries in Latin America, currently happening, as well in the US, which we do currently. All of us get messages from patients from all over the world requiring if we can assess their imaging or their case and guide their care or connect with their local team. So even if you feel that you are alone, you're really not alone. ALD Connect came to be to connect people. And I think that's one of the most meaningful and barrier decreasing barriers way that we have developed over the last decade to help anybody, any family that having to struggle with an ALD diagnosis.
Thank you. That was very insightful and still a lot of work that needs to be done. So, for the sake of time, we'll move into our last category of questions, which are looking forward, which these questions are directed to anyone who wants to answer them. The first question is for those meeting with legislators. I'm thinking this is mostly patients and families. What specific policy actions would be most helpful to accelerate treatment development or access that they should be asking for?
I can think of one that comes very quickly to mind. The states, for example, in the United States, if you're talking about this particular country, it would be ideal that the barriers of data sharing in terms of biomarker and how the disease affects people will be a little bit more common and easy to access and governed by a democratic kind of process where the data is deposited and accessible to researchers, clinicians, genetic counselors in a little more easier way. So policy and making that a more centralized process, not to take an autonomy from anyone, but to allow in a rare disease like this to have more robust data that we can then learn who's at higher risk of what kind of symptoms in the disease. That's one that I can think of.
Thank you. Does anyone else want to add to that? Okay.
I would just say, in general, funding public health and just being aware. I know newborn screening is almost in every state here in the US. It's not across the world available still in a lot of countries, but being aware that newborn screening is definitely underfunded, and also not only advocating for funding so that they can do the testing, but also for sharing and understanding like the right cutoffs for diagnosis, which I know is not treatment, but it's still, you have to identify the patients who need the treatment, and that still needs to be funded.
And another policy change that's been advocated by several rare disease is every clinician has to be credentialed in the United States, for example, to practice in different states. So we don't have a license to practice anywhere in the country. We have license to practice usually where we are or in a couple of states around us, depending on what practice we have. And it's something that has been pushed by several groups and is really trying to get for rare and ultra rare conditions the possibility of those that have more experience to be able to provide care in states that are not the states where they only hold their license. So if that could happen, the access to the expertise could be a little bit more easier and potentially even remote to guide the local team, not to replace it, but to make access to the expertise to other groups of physicians that can easily take care of the patient with a little bit of extra help or guidance with people that have more experience in these rare conditions. So that's another policy change that it will be very helpful. Um,
That's great. I hadn't heard of that before. That would be very helpful.
Yeah, NORD has, if you're interested in advocating for policy, the NORD as a foundation has a lot of action items of what they're trying to push for several rare diseases, and you can see which ones resonate with you in terms of speaking about ALD and what would you want to see happening in your state or in your particular condition.
Great.
This has to specifically do with single case agreements in recruiting patients to hospitals. So, which most of my patients are because of those barriers. And when we do that, everybody who sees the patient needs to have that out of state license, and it's a huge burden to try to accomplish it.
Yes. And delays, and time is brain.
Yep.
So the delays that happen are desperating.
Well, thank you all. And in our last minute or two, the last question that we wanted to ask for everyone is what is one thing that families should take away from the discussion today? And we can start with Dr. Mussolino, who very nicely put together this wonderful PowerPoint slide to encapsulate her thoughts.
I'm very visual. So yeah, I think you're not alone. That's the one take-home message. I know we have a limited amount of time, but the community for ALD is very collaborative, very collegial, and I think if you learn what you need to build your team to care for your family, the needs are different for everybody and for everybody in your family. Then you are empowered to really look for the resources and try to find them. And if you need help on identifying how do you build your team, you can always contact ALD Connect. That's my take home. You're not alone.
Thank you. Does anyone else want to add to this?
I'll just say, that I think there's a lot of, there's a lot of promising recent research and upcoming research that is focusing a little bit more on what the stated needs are, just in terms of thinking again about lifestyle recommendations, what are things that people can be doing to take care of their ALD, thinking about, women's issues, quality of life concerns. It, might be a little harder to find, but I know our colleagues at ALD Connect, are always willing and able and putting out, information as well as it comes out. So yeah, I think there's a lot of good information to be found if you're looking in the right places.
Thank you. Dr. Lund or Dr. Regelman?
Yeah, a lot of progress has been made. It's always hard year in and year out to recognize it, but if you look back 5 years or 10 years, we diagnose faster, better, earlier. Patients are being treated faster, better, and earlier. I know a lot of focus comes on cerebral disease, and some of the other manifestations need to do some catching up, like women and AMN, but clearly we are practicing medicine much better than we did 5 years ago. So we are making progress.
Great.
I'm going to echo everything that everyone has said. And the last thing I would just say is make sure you talk to your own doctor and that you're making decisions with your team based on you. And know that everyone is an individual and there are different reasons for management, and you should do what's best for you and your family.
Thank you. That's a wonderful reminder and a great note to end on. So want to thank all of our panelists today for taking time out of your day to spend time with us. Thank you to everyone who attended today and to everyone who registered and submitted questions that we were able to answer. We're so glad that you were able to spend the end of Rare Disease Month together with us, and we hope to see you again on a future webinar. Thank you for attending.
Good.
Thank you.
All right, thank you.
Thank you.
Thank you.